Hello and welcome to this session of Maritime Medicine. This is Dr. Jonathan Busco, and in this session we'll be discussing splinting. By the end of this session you'll be able to apply the following splints: a thumb spica, an ulnar gutter or boxer splint, a long arm, a long leg, a short leg, a femur traction device, and a sugar tong, although you will also need to read the associated download materials. If you have a suspected fracture or a fracture dislocation of a joint, your initial assessment is to localize it, determine whether or not there is joint involvement, and check the status of circulation and motor and sensory function. The next goal is stabilization. And what stabilization does is it prevents further injury because the broken parts aren't moving around against each other and against the surrounding soft tissues. It reduces pain because they're not moving, and this promotes healing. Keeping the fractured parts close to each other allows the body to do its healing process of building new bone. Now, very early on, you may just put on a temporary splint, do some stabilization with a wire splint or cardboard or wood or malleable aluminum like a SAM type splint or a pillow or a traction splint, and then manage their pain, and we use the pain ladder, which is discussed elsewhere. But you may also put on non-temporary splinting like plaster or fiberglass, because there are a number of fractures that you'll be able to manage shipboard the same way they'd be managed in an emergency department, and by managing them there you potentially prevent a patient having to be evacuated, because really the management that you can do without an x-ray is the same as the management that I would do in an emergency department with an x-ray typically. So we'll talk about some general principles of splinting. When we splint bones, we splint from the joint above to the joint below. Sometimes we extend it a little further depending on where the fracture is. When we're splinting an injured joint, a fracture right in the area of a joint, we splint the bone above and the bone below, and then sometimes we may need to go further. So if somebody had an elbow injury, for example, we're not going to let the wrist flop around because that will promote movement due to muscular and tendinous traction on the elbow, so we would splint the wrist as well. Our splints need to be tight enough to be secure so they're not going to fall off, but loose enough that they permit circulation, and adjustable. It used to be everybody got casted immediately, and then in 2 to 3 days the cast was cut in half. It's called clamshelled or bivalved and allowed to expand. Now we put on splints that allow expansion and then ultimately replace them with a cast. And before and after, we always assess circulation, motor and sensory function, the color of the injured extremity compared to the other side, the temperature, and the capillary refill. So we're going to talk splinting principles. The actual specific splints are covered in the associated handouts. So on the wrist, we're splinting from the distal humerus right around the elbow, but past the elbow, to the hand to just proximal to the fingertips. And so you look at that wrist, you can see it's deformed, and on the x-ray you can see there's actually both a fracture and a slight dislocation, and you can see how a longer arm splint is being placed on that patient to keep the wrist from moving around. And you want it just proximal to the fingertips. You need to be able to reassess the fingertips for sensation and capillary refill. So if we talk about a mid-forearm radius and ulnar fracture, not the distal one like we just saw in that last x-ray where it involved both the distal radius and ulna and the joint, but in the middle of the arm like you can see on this x-ray, and you can see the mid-arm deformity on this poor patient's arm, there you need to splint all the way up to the mid-humerus or even the upper humerus, all the way down to the hand to just proximal to the fingers to prevent movement. For the humerus, you can either break it proximally, which is very common in older patients, so you break it just below the humeral head, right where it comes out of the shoulder. Those are just treated with a sling and swath. They don't even need to be splinted, and oftentimes they'll heal up on their own just with a sling and swath. If you have a mid-shaft or distal fracture like the one you can see in that lower x-ray, however, they need a long arm splint that basically starts at the shoulder and goes to the mid or distal forearm, and then you put them into a sling and swath as well to help to immobilize that injury. With an ankle fracture, oftentimes you get a combination fracture dislocation, so you can see the ankle is dislocated from the joint and there's a distal fibular fracture there. So in that case, you need to go from just distal to the knee down to the tips of the toes, but just like you did with the fingers, leave the toes exposed so you can check sensation and capillary refill. If it's a mid-tibiofibular type fracture, you're going to need to get above the knee, because if the knee is moving, it's moving those bones. So you look at that x-ray, you can see it's broken in multiple spots, that leg's completely unstable. You're going to put a splint on that starts in the mid femur there and just above the knee and goes all the way down to just proximal to the tips of the toes. Now, femur fracture is really problematic. The classic femur fracture is the one you see on the lower left. That's the mid-shaft femur fracture, and we'll talk a little bit more about what you might do for that. But you can also get that sort of distal femur fracture. You can see the upper one where the bone is completely destroyed, and so not really overriding or malaligned because it's just destroyed, or the lower one where it's also a distal femur fracture where it is overlined. Now, the problem is with a fracture like any of these, you can lose up to a liter of blood or so in your femur, and so if you had them bilaterally, you can lose almost a third to half your circulating blood volume and go into shock just from that. Also, you've got a lot of nerves running through there and a lot of soft tissues, big muscle groups around that area that can have significant injury. And so you need to immobilize the entire leg, basically from the top of the wings of the pelvis, which you can feel if you push on somebody's back, just a handbreadth or so below the rib cage, you'll feel another hard structure. That's the top of the wings of the pelvis. And so you immobilize from there all the way down to just proximal to the tips of the toes. Now, you could potentially do traction splinting. So what you see here are images of what's called a hair traction splint. And the idea behind a traction splint is that you stabilize on the ischial tuberosity, the big bump that sticks out of the bottom of your butt, and that sort of central picture where the patient's laying on his side and you can see the proximal end of the traction splint is pushed right up against the ischial tuberosity. And then you attach a hitch to the ankle, and you can see that hitch on the ankle, and that pulls the leg out and straightens the bones of the femur fracture. They stop overriding. It helps reduce the muscle spasm of the quadriceps muscles and the other muscles, the hamstrings, and it decreases the risk of further injury. There are some problems with this. It's a fairly fussy process. These are not the only types of traction splints, but all of them are fairly fussy. It's hard to get exactly the right traction that you need. You need to be constantly assessing the foot for motor and sensory function, as well as circulation, because that hitch on the ankle can do both nerve damage and blood vessel damage. And the splints in general, we're not even sure that they particularly help. When this is done in the hospital, what's done is a pin is basically drilled through the unbroken distal femur, and weighted traction, the exact right amount, is hung on that. So it's a bit problematic. The other problem is if you also have an injury to the knee or an injury to the tibia or fibula below that, if you're applying traction, you're just stretching out those injuries. You're not applying any traction to the femur. So it has to be an isolated mid-shaft femur fracture, and those can be somewhat difficult to sort out. And then once you've put it on, you have to constantly keep adjusting it. That picture in the lower left-hand corner is somebody readjusting the tension on the traction splint. So for our purposes, putting on a posterior long leg splint that's a rigid splint as opposed to a traction splint is probably as good as a traction splint, or at least there's no evidence to suggest that one is better than the other, and it's certainly a lot easier to do. On the other hand, a traction splint does provide full leg immobilization. The other problem, which might be obvious to you if you think about patients on long spine boards or patients with who are bedbound, is that you can see where the proximal end of that traction splint is applying a lot of pressure to the ischial tuberosity. and there's a pretty good chance you're going to end up with skin necrosis and breakdown. These were never designed to be left on patients for a long period of time, more than a few hours really. And so in the austere shipboard environment where you're isolated from potentially from getting this patient to further health care, this device can cause a fair amount of injury if it's left on too long. The hip is actually typically the proximal femur that breaks, and in the elderly, they either fall and break their hip, or if they have underlying osteoporosis or bony disease, they break their hip and then they fall. These are fairly stable. There's not a lot of muscle spasm pulling on these. The upper image is a native hip that's broken. The lower image is actually a hip prosthesis that's broken. And so while you could put a splint on behind these, you can also often just pad them with a pillow or some other support and then transfer them in a non-mobile manner. So you need to review the two downloads. There's the Splinting Pocket Guide, which is techniques for the common splints, which actually tells you how to do them. And then there's one called the TOC brochure, Cast and Splinting. That's from an orthopedic group. And it's really good instructions, both so you can understand what needs to be done over time with these splints or splinting material, and also so you can give it to the patient so that they know what to do. Please complete any associated knowledge reviews, and if you have any questions, don't hesitate to contact your instructor or professor. Thank you very much.